with us on this panel, we'll have Behavioral Health Board roles and responsibilities that will be discussed by Teresa Comstock, the Executive Director of California Association for Local Behavioral Health Boards and Commissions, and statewide implementation updates by Lisa Felt, County Behavioral Health Director, Association Director of Policy, and local county implementation update by the Behavioral Health Director for Marin County, Todd Schirmer. So I want to welcome three of you and go ahead and turn it to you to move us forward with this section of the agenda.
Good morning. Can you hear me? Yeah. I'm Teresa Comstock. I'm Executive Director for California Association of Local Behavioral Health Boards and Commissions. And I have a presentation. It'll take about 15 minutes, but it has a lot of slides in it that you can go back to if you want to. And I think we tried to pass it around the room so you could see it. This touches on the philosophy, principles, and practice requirements in the BHSA funding for community planning, the behavioral health agency requirements and tools, behavioral health boards and commissions requirements for community planning, including membership and duties, and then toolkits. So a lot packed into the presentation, but I'll just touch on these subjects. And tomorrow we have our training for boards and commissions, so we'll go in more depth into this. So philosophies, principles, and practice requirements, just to refresh your memory, the Behavioral Health Services Act, the planning for services shall be consistent with the philosophy, principles, and practices of the recovery vision. And it should be person-centered, number one. Number two, promote consumer-operated services. Number three, reflect the cultural, ethnic, and racial diversity of behavioral health consumers and address inequities. And number four, plan for each consumer's individual needs. So we should be grounded in these principles through the planning process. There is funding that is available if counties want to use it. They can use up to 5% of their Behavioral Health Services Act funding, of the 5% of the total. And on top of that, they have administrative funding of either 2% or 4%, depending on the size of the county. So quite a bit of resources could be provided in order to just do the planning process. All right, I'm going to go into staff requirements just because I think it's important to understand what is required of the staff for the advisory boards. In order to advise, they need to know what the requirements are of staff and what to expect and how to ask staff for what they need. So these are integrated plans. The Behavioral Health Services Act funding is involved, but also we're supposed to be looking at other funding sources as well, since the Behavioral Health Services Act is part of the funding equation for these counties. And part of the requirements for planning are what are called cultural competence plans. And I think on the federal level, cultural competence is not wording that through an executive order we're supposed to be using anymore, although it's still a requirement. So this just reviews, some of those requirements in terms of being able to allow access to all communities and also to have outcomes that are beneficial to all communities. And then I've highlighted on this slide that there is a requirement for the behavioral health director to consult with the advisory board on the provision of services, establishment establishment of facilities, contracting for services or facilities, and other matters necessary or desirable in accomplishing the purposes of behavioral health in your counties. And so I just highlight this just to bring it to your attention that it is important to have these boards and commissions, that their membership requirements need to be met, that they should have their bylaws in place that correspond to California law, and that they should be a tool of the county in order to ensure that the public has access. So wanted to make sure that, and all of the boards or all of the behavioral health directors have to sign off on these Behavioral Health Services Act integrated plans and with performance agreements with the state that say that they do consult with these boards and commissions. All right. And Marlies touched on the requirements. There are a lot of requirements for stakeholder involvement, 29 different categories. You can't see it on the slide or on the printout because there are so many. But if you want to go to our website, you can see the documents. We have all of the documents I'm reviewing today at calbhbc.org/BHSA. So lots of requirements for meaningful stakeholder involvement, and we try to emphasize the word meaningful. I think in some counties, they have really pushed toward meaningful involvement. In some counties, we have kind of one big meeting, and I would say for 29 different stakeholder groups, that is not meaningful. The next slide just reviews the tools for community planning that were put in the policy guidance from Department of Healthcare Services. So instead of thinking, okay, let's have one big meeting for 29 different stakeholder groups, if we want it to be meaningful, I would suggest that this different types of tools from this slide and the next slide be considered. The first is education and engagement. The second, listening sessions. And we have a link here to a suggested toolkit for listening sessions. Conference calls, client advisory meetings, consumer and family group meetings, town hall meetings, video conferences, media announcements, targeted outreach, public comment, public hearings, stakeholder work groups and committees, focus groups, surveys, key informant interviews, or engaging with subject matter experts, and training, education, and outreach, plus other strategies. So many different ways if you want to have a community program planning process that is meaningful. Wanted to make sure that everybody's aware, that there are lots of ways to do this. In terms of the boards and commissions, they have membership requirements that help them represent the communities that they serve. At least 50% of members should be consumers or family members. And then of that, they should have at least one member that's 25 years of age or younger. They should have one board of supervisor member serving on their board, one employee from a local education agency, and one veteran advocate. And they should reflect the diversity of their community. Next item speaks to duties of the boards and commissions now. So I'm switching from staff to boards and commissions duties. One of the duties, and this is one of 8 duties according to California law, one is to review and approve the procedures, and we put that in bold, underlined, and capitalized procedures used to ensure citizen and professional involvement. So these boards and commissions, they don't need to approve the plans, not the integrated plans. They need to be approving the procedures. They need to be ensuring that the public is involved and listened to during the planning process. Second, they can review and advise regarding draft and adopted plans. And if they do vote on a recommendation to an adopted plan or update, the behavioral health agency needs to respond. Either they need to implement the recommendation in their next plan or update, or they need to explain why they didn't do that to the Board of Supervisors and Department of Healthcare Services. So it's in the community's interest also to be going to the board and commission if they really want a substantive recommendation made and make sure that there's some action. And then they also conduct the public hearing for the Behavioral Health Services Act integrated plans. I'm going to go to the toolkits that we provide on our website, and then also on the Coalition for Behavioral Health website. Lots of training tools. We have 15-minute modules so that folks can understand the community planning requirements, understand the funding categories for BHSA. Just kind of check your understanding in 15 minutes, get a brief overview, and it's good for new members and good for staff sometimes to look at those. We have presentations on community planning and unconscious bias, and we have the information on requirements and just resources in terms of like listening session toolkits and the tools that DHCS listed. As I said, we have the listening session toolkits. We want to make sure that this is not only during the listening session that it's meaningful, but before the listening session, that things are prepared for, that the staff has reached out to communities that don't always participate in these types of processes and start those relationships and get their leadership to be involved in the listening sessions. And then I'll end on this one. This is the California Coalition for Behavioral Health has started collecting toolkits for different populations. So children and youth, there's a toolkit. Older adults has put together a really nice recording and presentation and toolkit. And we have it, of course, for the boards and commissions. And then also just recently, we put together a presentation for peer providers to be involved in this process. So wanted to just highlight all of those resources to you. And then we have more on our website if you need more information to look at. That's it for me.
Thank you, Teresa.
Thanks.
Thank you. We're going to go to Elisa Feld, Director of Policy for CBHDA, who's going to cover statewide implementation updates.
Thank you. And how much time do I have, Tony?
Between you and Todd, what? About 10 to
minutes.
10,
All right.
10 to
Well, mine
15
will
minutes
be-
each. You're good.
We'll be quick.
Yeah.
That way Todd can have more
You,
time.
you guys are good. 10 to 15.
Well, good morning, everyone. As Tony said, Elisa Feld with the County Behavioral Health Directors Association, CBHDA. And so just wanting to provide an update on what implementation has looked like for the community planning process and integrated plan, generally speaking, across the state. So as Marlise noted, this is a huge transformation. This is not just simply a MHSA. Oh, I don't know what happened to my mic.
Right.
Okay. This is a significant system transformation. This is not just MHSA to BHSA with new categories, but really this is pulling in the entire behavioral health system and really joining other other huge statewide initiatives and linking them all together under behavioral health transformation. So you'll hear BHSA, you'll hear BHT, behavioral health transformation. Under BHT, there are a lot of other components that both counties and in some cases managed care plan partners and others are going to be held accountable for, like the statewide behavioral health population measures. And so I just don't want that. I think that that point cannot be reiterated enough. As a part of this huge change, the state, Marlise and team have been so wonderful to work with and answering all of the questions that our county staff have and behavioral health directors have, because there are so many nuances to this with the change. And so I just want to give a shout out to that, but also to note that because of all these unanswered, sometimes things aren't clear, they could be clearer, and counties do want to follow what is required in BHSA. Sometimes things are taking a little bit longer to figure out, or there could be some, there's some learning curves. So just wanting to really note that. On top of BHT, just to give some context, and Dr. J. Africa spoke to this a bit yesterday, there are all these other systemic changes happening at the same time. And then still continuing to implement some really fundamental ones from CalAIM, like payment reform and whatnot. So just wanting to kind of give that overall context. Some of the highlights that have come out, and I believe Jay spoke to this, and Teresa, you kind of spoke to this a little bit, is with the additional added partners that are required in statute for the community planning process. This has really kind of opened up the door to have more of those conversations, to invite groups to the table that maybe weren't aware of the county process or just didn't know how to get involved. We have heard from counties that there are, and as you all know, every county has a completely different makeup of partners in their community. We have heard from some counties that have been some partners that are a little bit harder to engage, and these are some of the newer ones, but really trying to find ways, going off of that list that Teresa pulled up that comes from the policy manual of all the ways to engage community partners. Some of the things that folks have found to be really useful is doing one-on-ones or key informant interviews with some of these newer community partners. And that way their voice is not lost in large meetings, particularly if it's more sensitive. I know we had a few counties kind of to give an example of like, well, how can we meaningfully include like domestic violence survivors without, calling that out in a large meeting, right? That would not be appropriate. So really finding creative ways to reach communities that have not been involved or have maybe not been as deeply involved. The other silver lining of this is under MHSA, it was, MHSA was used to leverage a lot of federal financial participation, or FFP. A lot of the community stakeholder processes were kind of focused on how are we going to spend our MHSA dollars, right? And it was very kind of focused on MHSA and those requirements. Well, now that the planning process includes all of the funding streams and includes our substance use disorder delivery system, as well as looking at our specific delivery systems like the children's system of care, adult system of care, counties have shared that there has been, it's been really helpful in helping to educate the community about what the whole delivery system looks like. And so that has become a necessity with planning because it's not just MHSA dollars now. So counties have a lot of obligations and responsibilities, and then under BHSA, they get even more specific, right? Of like where we need to spend percentages of the money. So that has been, I've heard from multiple counties, that has been so helpful, not only for the community members, but the behavioral health board to understand things like, oh, we could get sanctioned if we don't meet network adequacy requirements or timely access, or some of these other Medi-Cal obligations that counties have as health plans that are really looking at the system as a whole. BHSA is challenging because of the redirection of funds. So we have new funding categories now. A third of it is going to housing intervention specifically. That is a lot of lost dollars that we can leverage for FFP, which just gives counties more dollars to spend on things. So there are some significant shifts, prevention being one of them. Prevention activities are no longer allowed to be spent with BHSA dollars. And so what our county leadership has been really trying to do across the state is to kind of ground folks, and let's not focus on specific programs, but let's look at the system as a whole and what are our goals and where do we see there might be gaps, because there might be some things where it's not necessarily BHSA dollars that fund it, but maybe it's another funding source, or maybe a program can be looking at existing programs and going, okay, well, we can't fund prevention, but could we add an aspect to this existing program to try to meet this need? So really looking at being creative, but looking at the system as a whole versus just looking at like one individual program, because of all the necessary braiding of funding that is required, that is something that counties have been doing for a long time. And now with the shift with the integrated plan and the community planning process, this is really kind of raising a lot of that stuff to light for folks that were potentially not familiar with it before. Another positive silver lining is the increased partnerships with public health and with our managed care plan partners. We have actually seen a few managed care plan partners really step up to the plate actually, and starting to have the conversations of, okay, you're starting to, like, you have to cut these prevention programs. Are there ways that this could potentially be covered in something else that we do? So managed care plan partners have community reinvestment requirements. We have community supports now, which not all prevention activities fall under there, but we have some that are really coming to the table in a meaningful way to look at the system as a whole, not just your county behavioral health and I manage care. And then also counties have had strong relationships with their public health departments because they are under one roof, but this is becoming, they're having even deeper conversations given the requirement to collaborate with the community health assessment and then the community health implementation plan, the CHA chip, that's in the policy manual. I will just note that for kind of turnout for some of what we've heard from counties is particularly some of our larger counties, they are using multiple methods of community planning and doing many of those ones that were on the screen, even for ones where they are doing kind of a specific like subset of the population. For example, like, really trying to, this actually came up in one of our larger counties, reaching out to older adults and seniors. And so they actually had like 200 people show up to that meeting. So, and that one was focused on, on that specific population. So it is a lot to meaningfully engage all, I think, is it 28 or so? Is that how we're at? 29. Okay, I was close. 29, 29 unique groups, and really being able to understand what their needs are and helping them understand what the system looks like and also the limitations. We have a lot more limitations on how we can spend our BHSA dollars now, given the requirements under FSP to provide evidence-based practices to Fidelity. Those are quite expensive and that will take a chunk of change. And then some of the other, and again, the housing, we are so excited that housing is not coupled with FSP anymore, because that was the way we could pay for housing prior. So we are glad that that's uncoupled, but that is still a chunk of change. And so counties are having to really think creatively and innovatively and really trying to do that in partnership with their communities. I think I'll pause there because I would love to hear what Todd has to say, and we'll probably have, a lot better things to say to me.
Thank you, Lisa. Good morning, everyone. My name is Todd Shermer. I'm the Director of Behavioral Health and Recovery Services for Marin County. Thanks for the invitation here today to talk about a county perspective on the BHSA integrated plan and community program planning process. So for a bit of background, Marin County's Board of Supervisors was the first county board to go on the record supporting Proposition 1 in the March 2024 vote. And nearly 2/3 of Marin County voters supported it. So we saw this as a clear local mandate to move forward as quickly as possible with BHSA implementation. So we began our community program planning process as early as we could. We actually started in November of 2024, so almost a year ago now. And we concluded our process in June of this year. So we had about an 8-month community program planning process. During that time, we had over 30 community planning meetings across the county, both in person and virtual. We held them during the day and evening hours and weekdays and weekends to try to engage as many folks as possible. We had focused discussions with people who had lived experience, families, older adults, early childhood providers, our staff members, LGBTQ plus community members, to try to hit all 29 required groups. Marin County has Spanish as one of our threshold languages. We also have a growing population of Vietnamese speakers in our community. And so we had a number of meetings fully in Spanish and one meeting fully in Vietnamese, and then provided interpretation for all of the meetings. We also did present to a number of boards and commissions in our community, including our County Commission on Aging, our advisory board on alcohol and other drugs. And then for our behavioral health board, BHSA and MHSA has been a standing agenda item. And we provide regular presentations and receive community feedback pretty much every month at that meeting. We feel that ongoing input does ensure transparency, collaboration, and accountability. We've also presented to our County Board of Supervisors twice this year in February and September to keep them updated, and in a public setting to keep the community updated on our projections and our planning process. In addition to the meetings, we also developed a survey that we distributed both in English, Spanish, and Vietnamese through our email list, social media, local papers. We distributed thousands of these surveys. We got about 200 of them back. We did some in-person outreach to youth and homelessness-focused events where we provided that survey. Our goal really to capture as much information from our residents who might have language or technology barriers. So the results of our community planning process, we had obviously a ton of data, a ton of priorities. So as we attempted to synthesize this, we came up with 7 key community priorities. This included addressing barriers to services. So getting people in quickly, understanding our system, reducing wait times, and then regional equity. Marin County is a medium-sized county, but it does have a substantial geographic area that is relatively unpopulated. Housing and supportive housing services, including permanent supportive housing, sober living, other types of supportive services. Continued expansion of our crisis services, such as warm lines, mobile crisis, and other alternatives to crisis programs. Substance use treatment across the lifespan was another priority. Culturally responsive services, including bilingual, bicultural, LGBTQ+, and other underserved communities came up repeatedly. Peer support has long been a key priority of our community for many MHSA cycles, and it does continue to come up in this first BHSA cycle. And then lastly, early intervention across the lifespan. So we did have a number of challenges as we went through this process. Obviously, we were trying to move quickly. And so as a result of that, we started our planning meeting before we had final guidance from DHCS or the Department of Public Health. And so we had to kind of tread carefully about what we were saying and what we were promising to the community when we didn't know fully what we were going to be required to do. We had a very compressed timeline due to kind of the public comment, the notification requirements, the new DHCS review step. And then Marin County, like many counties, has I would say, a fairly cumbersome procurement and contracting process. So we did sort of try to time it back from July of 2026. How long would it take us to do requests for proposals, contracts? And so we were targeting December as a date to have final approval of our integrated plan. We did see lower participation among Spanish-speaking residents, and we hypothesize that's due to federal immigration enforcement activities and the need for culturally safe engagement. That's part of the reason that we decided to do a survey in addition to the actual meetings. And then lastly, as a sort of early submitter to DHCS, we did experience some technical challenges with the submission of our integrated plan. Thanks to Marlise and her team for helping us through that process, and we were able to do all the technical pieces. So ultimately, we did complete our plan and post it publicly on October 3rd. So we're currently in our 30-day review period, and we were able to submit it to DHCS on the 8th. We do have our public hearing at our Behavioral Health Board meeting on November 4th, so just a couple of weeks away. And it's our target to have our Board of Supervisors approve that final plan by December 9th. And if we hit all of those dates, then that means we can begin the request for proposal process in January and do all of our contracting over the following 6 months for full implementation by July 1st. All right, so thank you very much.
Todd, thank you so much for your portion as well. And a lot of work going into this part of the process. And I know that counties are very, very busy during this time with the plans and implementations and everything else that's coming at them. So we really appreciate the fact that you were able to come down here and give us what's going on the ground. So with that, we're going to go to questions by the council members. Uma, go ahead, please.
Say, as an early implementer, you're really, really early. I'm trying to get my head around something, which is Marin County, how do I say this to be right? Are you having new programming that you're thinking you're bringing on board, or are you transitioning existing programming into BHSA? Because there has been a lot of questions around how the funding matches up with the buckets and how you make it all work, and some programs fit better or not. So question is, given that you're so early in your planning process and implementation process, did you work all that out, and the public process, the input you got was specific to that, or was your input process from the community more broad strokes, and then you backed into what you're doing?
Thank you for that question. It is a really important question. So we are expecting some substantial changes to our programming as a result of BHSA. We have been projecting somewhere around a $12 million gap in our budget, and the need to move things around so that we can address that budget. And that will include some program cuts and program consolidation as we move forward. Largely, our community program planning feedback was, I would say, high-level feedback, kind of big picture priorities that will help us as county staff sort of design and modify the programs to fit within those priorities.